to introduce our speaker, a well-respected physician and educator. Dr. Nzinga Harrison is the Chief Medical Officer for ANCA Behavioral Health Incorporated. She's earned her bachelor's degree in biology with Spanish and chemistry minors at Howard University, completed medical school at the University of Pennsylvania School of Medicine and general psychiatry residency at Emory University. She is a board-certified in adult general psychiatry and addiction medicine. Currently, she holds adjunct faculty appointments in both the Nell Hodgson Emory School of Nursing and Morehouse School of Medicine, Department of Psychiatry. She is a wife to a stock market day trader and a mother to 2 sons, aged 7 and 9, a combination that ensures she was never without a funny story to share at a cocktail party. So with that, I'm going to go over and turn it over to Dr. Harrison.
All right, good morning, everyone. So hopefully we have some repeat attendees from the last time we were on. If not, or if we also have new people, this talk can stand alone, but I would strongly encourage you to take a look at Adolescent Drug Use Part 1, as we will be making some references to that. So let's go ahead and jump right in. Today we're doing Adolescent Drug Use Part 2, Current Trends. Our learning objectives for today. Now, I don't know why my slide, there we go. It was refusing to change the slide, but now it has cooperated. Here are our learning objectives for the next 45 to 50 minutes. We're going to discuss the implications of legalization of marijuana as it relates to adolescent drug use. So this is, of course, like the hottest topic in so many different places, and adolescent group home workers will definitely start seeing some impact of this coming pretty quickly. So we'll talk about how to think about that and how to manage it in your treatment setting. Number 2, we'll discuss other current trends in adolescent drug use. This will mostly be around the use of designer drugs like spice and bath salts that don't necessarily show up in your garden variety urine drug screen. We'll talk about what they're doing in the brain, the symptoms to look for, and the prevalence of use among adolescents for that specific drug class. And then finally, we'll talk about how to apply the knowledge of current trends and the implications of marijuana legalization and designer drug use when you're trying to design prevention and intervention strategies for adolescents. So here we go. Legalization of marijuana. Believe it or not, marijuana is the 3rd most popular recreational drug, and you may have thought to yourself, what? I thought it was the 1st, but don't forget that alcohol and tobacco are also considered recreational drugs. So only behind alcohol and tobacco is marijuana use in the United States. Nearly 100 million Americans have used marijuana. So the use is extremely widespread. This chart is from the National Study on Drug Use and Health, 2012, and it shows you basically in this study, SAMHSA, the Substance Abuse and Mental Health Services Administration, so that's out of the federal government, does a survey on drug use and health every year, and they call a representative sample of Americans across the country and ask lots of different questions about health, mental health, and drug use. And one of the questions they ask is, have you ever used marijuana in any form? And so the first 2 columns you see there are 2011 and 2012. Yes, ever in my life I have used marijuana. And in the left-hand column, broken down by age, you can see 11% of 12 and 13-year-olds have already smoked marijuana at some point in their lifetime. I mean, that just makes my eyeballs fall out. I do not want to think about my 12-year-old and 13-year-old already being involved in recreational drug use, but that's basically 1 out of 10 12 and 13-year-olds has already used marijuana by the time they get that age. When you get to 14, 15, and I'm just doing a kind of a combination of 2011 and 2012 numbers, that number rises to 15%. Look at this. When you get to 16 to 17 years old, that number rises to 1/3. 1 out of every 3 16 or 17-year-olds has smoked marijuana, has used marijuana by any method, so that would include marijuana brownies or other modes of delivery at some point in their life. When you get to 18 to 20 and 21 to 25, it's like half of people, 1 out of every 2. And then when you get on the other side of 35, that number gets to about 40, and then it stays there because basically if you've ever used in your life, once you get into this bunch, you don't drop out. So looking at the age of adolescents that are coming into your program, I'm making an assumption here that it's probably going to be between like 13 and 19. You're looking at anywhere from 10% to half of those adolescents having already smoked marijuana at some point in their lives. And this is just a representative sample across the whole country. That doesn't even take into consideration that adolescents coming into your program are going to be at even higher risk for having already had experience with alcohol and other drugs. So your numbers might be even higher than 1 in 3 or 1 in 2. That's lifetime. When they ask the question, in the past year, have you used marijuana in any form? Then you can see the numbers are a little bit lower. From 12 to 13, though, still like 7% of those kids have used in the past year. When you get to 14 to 15, that increases a bit to about 12%. And then at 16 to 17, we're at 1 in 4. By the time we get to 18 to 20, we're like 1 out of 3. That has used in the past year. When we take the next step and say, okay, in the past month, so this is really where the survey is trying to get at who is a regular user of marijuana, because if you've used it in the past month, chances are you use at least once a month. 12 to 13-year-old, it's much lower, right? So our youngest adolescents really are not regularly using marijuana. And what this most likely represents is that they've tried it, but they have not yet become regular users. The same is true for about 14 to 15, but then when you get to 16, 17, 18, 20, you get into a bigger group who is regularly using marijuana, between 15 and 20%. So if you turn that into the 1 out of how many, that's like between 1 in 5 or 1 in 6 adolescents from 16 to 20 years old is using marijuana regularly. Again, this sample is just a low, like a regular risk sample, just representative of who lives in the United States. If we were to do this same questionnaire in adolescents who have had an admission to a residential treatment facility or a group home, that number would be significantly higher because that experience is a risk factor for having regular marijuana use. So basically, your risk for the adolescents you're taking care of is even higher than 1 out of 5, which basically means everybody, right? And this is why we screen everybody as part of the assessment for substance use, because it's just so prevalent. When we talk about the legalization of marijuana, I really want to draw a distinction between 3 different things, and that's legalization, decriminalization, and medical marijuana. So when we look at, because these are happening kind of, spotty, but the momentum is there. This will spread across the entire country, and we'll look at a picture of the United States on the next slide. But it's coming. So it might start just with medical marijuana and then go to decriminalization and legalization, but it is coming in the next several years. Marijuana will be legal just like cigarettes and alcohol at a certain age group. So legalization, this means individuals can buy marijuana for personal use from a safe legal source. Literally, like you can walk in the store, show your ID as long as you're 18 and buy a pack of cigarettes. That's what legalization means. But also, just like if you're not 18 and you buy a pack of cigarettes, you just broke the law, and the person who sold the cigarettes to you broke the law. This is what legalization of marijuana will be. So you can walk into whatever, the gas station, show your ID, you're 18 years old, you can buy marijuana, that person can sell it to you, it's legal. Decriminalization, on the other hand, does not say that marijuana for personal use is legal. It just says we're not going to put people in jail over it. So this is actually one of the biggest reasons why supporters of the marijuana legalization movement want marijuana legal, is because they want it decriminalized. The psychosocial consequences of marijuana use have far outstripped the biological consequences because of the laws that we have around it. And, you know, like 3 strikes you're out. You can have like 3 possessions of marijuana and theoretically go to prison forever, which is excessive. Now, that said, a lot of people have kind of made the leap that marijuana is completely and utterly safe, and the answer to that is definitely not. So it is without question, the literature shows that individuals who start smoking before 18, and this is the population that you're dealing with, have long-lasting, irreversible changes to the brain, changes, loss of IQ points, and changes in other cognitive functions that can affect them later in life. So the position that we need to adopt for adolescents is that marijuana is still very dangerous. Now, medical use of marijuana is the practice of using marijuana in various preparations. So you can smoke it, you can use it. There are tablet forms like Marinol. You can use a liquid, elixir. You can put it in brownies, gummy bears, lollipops. There are all sorts of different formulations. But it's basically prescribed by a healthcare professional as a treatment for medical illness. And there's good data that marijuana works for nausea, vomiting, weight loss, and chronic pain syndromes, as well as some other neurological disorders like multiple sclerosis. But there is no well-done systematic data that supports the use of marijuana in any psychiatric illness. So people will say, oh, I smoke marijuana for anxiety. The data shows that initially it can help anxiety, but ultimately it makes anxiety worse because marijuana can actually cause paranoia and make psychotic symptoms worse. So there's no good data to support it for depression, anxiety, paranoia, or any other psychiatric illness. But there is good data for some of those other conditions that I mentioned earlier. So it's important when you talk about legalization of marijuana to know the difference between these 3 different, I guess I can call them levels of legalization, because they really have different implications. For medical use, a physician may prescribe medical marijuana in an adolescent, but would have to appreciate the additional risk that marijuana has in the brain of an adolescent younger than 18 as opposed to a brain of an adult older than 18 or 22-ish, where your brain has finished its development. Decriminalization pretty much equally affects adolescents and adults. Legalization inequitably affects adolescents and adults because nobody is advocating for legalization of marijuana for people under 18. That said, legalization of marijuana for people over 18 is definitely going to affect teen use. And we're going to touch on some of the ideas we discussed in Adolescent Drug Use Part 1 to try to explain that. But before we jump ahead to that, take a look at this map of the United States. As promised when we were on the previous slide, marijuana legalization, medicalization, decriminalization is spreading across the United States. So this is a map off of the website NORML, N-O-R-M-L, which is an organization that advocates for the legalization of marijuana. And you can see what I've asked it to show on this map are those states where marijuana has been decriminalized, which is depicted by a little chronic leaf. So here I can put my pointer on so I can show you. So decriminalized here, you can see, shows a little marijuana leaf. Legalized actually shows a little marijuana joint, which is funny. They're symbols that they've chosen. And then medical marijuana shows the Red Cross. So if you look, there are far more states that have either legalized, decriminalized, or medicalized marijuana than there are who haven't. There's quite a bit, you can see here on the East Coast, of medical marijuana, so that's going to be the most common adaptation of marijuana at this point. And then there's quite a bit of decriminalization, which is marked by the marijuana leaf. And then the only two states who have actually legalized recreational marijuana are Colorado and Washington. That happened in January of this year. So January 2014, both Washington and Colorado made it legal for 18 years old with ID to buy and use marijuana for personal use. So what could be the implications of this? This is the main question that we're worried about right now for this particular talk. Will legalization of marijuana increase teen use? So let's start first with baseline statistics on teen use of marijuana. We looked at it a little bit on that first slide when I was just talking about marijuana use in general. But this is from the National Study on Drug Use and Health. This is 2012 data. Lifetime use from 2002, to 2012, you can pretty much see past month use, those are going to be your regular users, past year use, and lifetime use. They're relatively flat. It's not really increasing. It's not really decreasing. I guess you could say past year use decreased a little bit. Looks like it went from maybe about 16 to about 14. Lifetime use has decreased from about 20 to about 17. But those are not likely statistically significant. So basically, in the last 10 years, marijuana use among teens aged 12 to 17 has remained relatively unchanged. When we look at the states that have legalized medical marijuana, 20 states, including Washington, D.C., have medical marijuana laws. 15 of those states have produced before and after data on teen marijuana use. So they looked at their prevalence data. How many teens are lifetime, past year, and past month users before they passed medical marijuana? And how many are lifetime, past year, and past month users after we made medical marijuana legal? And is there any difference? Of those 15 states that have before and after data, Maine is the only state that had a statistically significant change. So that means of the other 14 states that collected data before medical marijuana was legal and after medical marijuana was legal, 14 of their states, medicalizing marijuana had absolutely no effect on the rates of teen use of marijuana. In Maine, however, there was a statistically significant change, and get this, the rate decreased. I don't know what's up with that. I don't even have a hypothesis for why that is the case, but this study was done in response to this question. Will legalization increase teen use? Because that's what we're afraid of, right? We're afraid if we adopt medical marijuana, then even more children and adolescents are going to use. This data says it doesn't happen for medical marijuana. So medical marijuana for children and adolescents is like extremely controversial because, as I mentioned earlier, we have consistent data that regular use of marijuana during the brain developmental years, which is ages 0 to 22, changes and permanently can impair brain functioning. So you really would have to have another illness that is just significantly risky and unable to be managed through more conventional means before a physician is going to be willing to prescribe medical marijuana for children. Now, my hypothesis about why 14 of 15 of those states did not see any change in their adolescent marijuana use after they adopted medical marijuana laws is because adolescents, one, don't go to the doctor without their parents, and two, are not going to go to a doctor and request marijuana, and three, the doctor is not going to give it unless there is really a compelling reason to take that risk. So medical marijuana really doesn't touch adolescents for those reasons. For that reason, we separated medical marijuana, decriminalization, and legalization, because decriminalization and legalization will touch adolescents. So let's take a look. If we look at smoking and legalization, so right now, the only two states that have legalized recreational marijuana are Washington and Oregon, and it just started in January. So it's not enough time to really collect any data, and nothing has been published about it. But we can look at the comparison, like a similar situation that happened in the past, and that's with cigarettes. So I kind of just thought like cigarettes were always illegal, but it's not true. Cigarettes didn't actually get illegal for people under 18 until 1998 for all 50 states, right? It started for some other states a little bit before that, but by 1998, all 50 states had a law that prohibited selling cigarettes and people under the age of 18 using cigarettes and other tobacco products. So let's take a look at this graph. On your left-hand side, you have the percentage of people who are smoking cigarettes, and on the bottom of the graph, going across the slide, you have the year. You can see right there, give me my arrow, right there at 1998 is where among students and also adults, I mean, you had a steady decline among adults, but you fall over a cliff for students, right? In 1989, students started thinking it was cool to smoke cigarettes, and it goes up, 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 up. And then all of a sudden, 1998, smoking is prohibited for people under the age of 18, and look at that precipitous drop. It drops from almost 40% to less than 11% by 2011, right? So what this is showing is that criminalization or legalization does make a difference. This is the reverse. So the hypothesis, what people are really concerned about, and this is what we're going to talk about on the next few slides. Right now, we have marijuana is illegal, and we're talking about legalizing it. So we would expect that that red arrow for the line to start going up in terms of number of adolescents who will be using marijuana. And why do we think that? That goes back to what we were talking about in Adolescent Drug Use Part 1, which was developmental tasks of adolescents. Remember, the developmental task is to form their own identity, to become individuals from their parents, to develop their own moral and ethical self. That is guided by mores and ethics of the community in which they live, to develop critical independent thinking, cause and effect thinking, and finally abstract thinking. And part of being able to develop cause and effect is taking risks. Remember, we said the lower the perceived risk, excuse me, the lower the perceived risk, the more likely the adolescent is to engage in that behavior. And it's just a fact, sorry about that, it's just a fact that a behavior that is illegal is perceived to be riskier than a behavior that is legal. So by introducing legal marijuana, we're sending the message to our adolescents that marijuana is not risky, when we know that it is risky to the developing brain. So take a look at this. NORML is the organization that I referred to earlier. Their mission is to move the public opinion sufficiently to legalize the responsible use of marijuana by adults. So they specifically, not even NORML is advocating for marijuana use in adolescents, but the message, adolescents will accept that message. Oh, if adults can do it, it must be safe for us to do it. NORML wants to serve as an advocate for consumers to ensure they have access to high quality marijuana that is safe, convenient, and affordable. When you look at the developmental spectrum of early adolescence, mid-adolescence, and late adolescence, the abstract thinking and cause and effect thinking that is required for that last sentence, access to high quality marijuana that is safe, convenient, and affordable, that is really a late adolescent, early adulthood skill of thinking. But the risk taking for initiating drug use, remember we talked about that in part 1, really starts in mid-adolescence before this level of thinking is available. So by sending the perception that the risk of marijuana is less without having the critical thinking skill that comes in late adolescence makes my hypothesis this: yes, legalization will increase teen use. Now, at this point, it's just a hypothesis, right? Washington and Oregon will start generating this data for us. We'll probably get the first set in January of next year because there will have been a whole year. But this is my hypothesis. And the reason my hypothesis is yes is because it's grounded in adolescent development. Adolescents try new behaviors based on perceived risk. Illegal substance has higher perceived risk. Legal marijuana has lower perceived risk. Therefore, I hypothesize that use will increase. Availability will increase because as availability to adults, there will be no barrier to an adult buying marijuana. And so as availability to adults increase, availability to adolescents will increase, even though they will have to show their ID and not be able to buy it in a store. They'll be able to get a friend who's 18 to buy it for them, just like it used to be for cigarettes. Parental acceptance will increase, right? A lot of parents have been using it's illegal, that's why you can't do it, as their reason why they tell their kids not to do marijuana. Well, that's going to be removed. And so now what we have to do is take that next step of education for parents and say, even though it's legal, just like cigarettes are legal, we don't want you to smoke them. Just like alcohol is legal, we don't want you to drink it before you turn 21 because these are the risks to the developing brain. And then peer group acceptance. So adolescents in general accept marijuana. It differs by generation, right? So it's kind of a U-shaped peak with the flower children having higher acceptance and the baby boomers have a lowering acceptance and the adolescents coming up behind them. But remember, adolescents, if their peer group accepts it, they are more likely to try it. And more of their peers will accept it purely because it's no longer illegal. So my hypothesis is yes, 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 for legalization of marijuana leading to increased use in marijuana among adolescents. So the practical implication for you as someone who works in a treatment program for adolescents who are high risk is to be able to have that conversation. Even though it's legal and even though that decreases the risk, let's talk about the risk to your brain, which is still developing. Decreased IQ points, decreased cognitive performance, which translates into more difficulty in life down the road. So that's legalization of marijuana. We'll take the next step, which is just adolescent trends in general. And the one trend I want to talk about in drug use is the use of synthetic drugs or designer drugs. So this is the same graph that we looked at before. It was just marijuana pulled out by itself. This is illicit drug use period for adolescents, and that actually includes, you can see right here, non-medical use of psychotherapeutics. So that means using prescription medications not as they have been prescribed. And you can see, by far, heroin is the lowest illicit use drugs among teens. That's because teens perceive heroin to be very risky. Cocaine is followed there. Again, they perceive cocaine to be very risky. Hallucinogens are more common. They have less risk attributed to hallucinogens. Inhalants, they feel are even less risky. And then look at this. I mean, this is like 4 times as common as all of the rest of the other groups, which is non-medical use of psychotherapeutics. So there really is a decreased sense of risk when it comes to popping a pill. That has implications for how much our kids will be using it. So looking at synthetic drugs or designer drugs, really there are 3 big categories that are very much like big time on the streets right now. We have synthetic cannabinoids. So marijuana is a cannabinoid. It's a naturally occurring cannabinoid. Synthetic cannabinoids basically is what you've heard of called spice. So you see this little package up in the corner. You can buy it pretty much out of like any gas station, and they sell it under the auspice, under the idea that you're buying incense, but they know what the kids are buying it for, and the kids know what they're buying it for. It's spice. You usually like roll it in a joint and smoke it. Then there are bath salts. Bath salts have a different biology than spice. They're in a group which is called cathinones, which just has to do with their chemical makeup. But this is a picture of what bath salts look like. And typically bath salts are either going to be sprinkled in a joint and smoked or put out in lines like cocaine and snorted. And then, of course, you have MDMA, which is ecstasy. We're not going to spend a lot of time on ecstasy because I think you guys probably know a lot about it. It's been around for a while. But we will spend some time on spice and bath salts. So let's take a look. Spice. Here are common street names for spice. You see that? Afghan incense, Bank Silent, Barely Legal, Fire and Ice, Genie, Green Buddha, etc., etc. This is really marketed to adolescents. You can see their Scooby snacks. Like, these are not names that are designed to entice adults. This spice is being marketed to adolescents, and they think it's super safe. And they know that it does not show up in a standard drug screen, and that makes it very attractive for them to use. When you look at bath salts are kind of more marketed towards adults. You can tell by the names, Bliss, Bloom, Blue Silk, Charge Plus. It's kind of like very abstract, psychedelic type of name. So think again back, like it's called Sextasy, right? You can see that name down there. They're in alphabetical order. Think back again to the thinking level of the early adolescent, the mid-adolescent, the late adolescent. The spice is really kind of, those street names are directed at adolescents that are still kind of straddling that childhood adolescent, whereas bath salts is a little bit more abstract, a little bit more complex type of thoughts. And then MDMA, again, completely marketed to the young adolescent group. Beans, candy, dancing shoes. Like, you can see how these concepts are really very young. The hug drug, the love drug, Skittles, sweets, right? So that is definitely being marketed to our young adolescent group. When you look at synthetic cannabinoids, or spice, I'm just going to call them spice from now, they do not actually look like THC chemically. They're not produced by cannabis plants, but they do act in the same places in the brain and the body, the same receptors as THC, which is the main ingredient in marijuana. The risk with spice is so much greater than cannabis. We are seeing an increase in kids coming to the ER with brain swelling, seizures. Kids have died. Spice is more potent than cannabis. And really, this is the most dangerous part, is this last bullet point. You have, because it is synthetically manufactured, we have no idea what is actually going into these packets of spice that kids are picking up. And so that's part of the reason why toxicity and accidental overdose are more likely to occur. But again, remember, spice was being marketed to that early mid-adolescent group that does not have that complexity of thinking. They have the risk-taking without the appreciation for consequence, and that is making it especially dangerous. Usually spice is sprayed over an herbal or dried point, and dried plant matter, and then rolled into a joint so they can smoke it to get high. You can buy it off the internet, gas station, liquor store, convenience store, and it produces a high that is similar to marijuana. So what the kids are looking for is a way they can get that marijuana high without having that drug screen become positive for marijuana. Before we move on to bath salts, the implication of that in your program is that intoxication is not only diagnosed by a positive drug screen. If that kid looks high, even if the drug screen is negative, that kid is probably high on one of these designer drugs that doesn't show up. So moving on to bath salts. Bath salts have become increasingly popular. It is reported that they have marijuana-like effects, but we're going to look at kind of bath salts chemically and see that there's so much more. Again, they're readily available. You can buy them in the drugstore. The routine drug screen does not show it. You can get a super duper drug screen, but they're not widely available and very expensive, and our adolescents know that. When you look at how many college students are using it, only about 8 to 14% of college students are using bath salts, and it's even lower in the early to mid-adolescents. Remember, I said that's not really who it's being marketed to. It's being marketed to the late adolescent, and it is more common in males. But look at this. By 2010, already we had 11,000 emergency department visits that involved the use of bath salts, and 3/4 of those were between people aged 12 to 29. So, I mean, the prevalence is definitely increasing, and they are not safe. They typically take the form of a powder, which is either white or brown crystalline powder. The package will be labeled not for human consumption, and like these are the code words. It's plant food or it's jewelry cleaner, but an adolescent who is going in the store looking for this knows what they're looking for, and there is no regulation to keep them from buying it. This is not the same substance you put in your bathtub like your bath salts, okay? But what it is a synthetic modification of a naturally occurring substance known as the cod plant. And whenever you get into synthetic modification, you see that risk because you don't know what the street chemist is putting in there to make it stretch, and you see toxicity and you see overdose. So this drug is mostly in late adolescence to early adulthood, those between 20 and 29. They're really stimulants. So even though they're marketed as having a marijuana-like effect, the effect actually is more similar to amphetamines, methamphetamines, or ecstasy. They're typically injected or snorted. So when you talk to adolescents, snorting and injection are considered high-risk forms of drug use, whereas taking a pill and smoking are considered low risk. And that's another way that you know bath salts are really being marketed to an older group because they go along those higher risk methods of administration. If you see, so remember in the first talk we talked about developmental phase. How old is this child? Where do I expect them to be? Are they actually there? And if not, what's contributing? So if you have a 13 or 14-year-old who's using bath salts, they're really kind of operating in a higher risk place than you would expect for a 13 or 14-year-old. And that makes you want to look deeper. So ecstasy, I said we would mention it. It also is a stimulant and has some weak hallucinogenic property. It's typically taken by a pill that dissolves on the tongue. So it's a pretty low risk method of administration as far as adolescents are concerned. So when you look at how will you know, because I just told you you can't even necessarily look in the drug screen and see these, the way you know a kid is high, you know how to recognize it. They're confused, they're agitated, they're irritable, they might have hallucinations, they have physical symptoms, red eyes, their heart's beating a little fast, they look sweaty, right? You can see that with spice. For the bath salts, they really think of what people look like when they use amphetamines, so wide eyes, impulsive, aggressive, blurred vision. They might have increased blood pressure. So if you see these, even if the drug screen is negative, I want you to think to yourself, this might be spice, this might be bath salts, especially because the drug use is negative. So when we're looking at the trends, the legalization of marijuana, decreased risk equals legalization leads to decreased perceived risk will most likely lead to increased use. With the designer drugs, the kids perceive this risk of these to be very low, even though like the risk is very high. And so they're using it more and more and more. So when we talk about prevention, what we know is that not all adolescents are created equal, right? The early adolescent really is different from the mid-adolescent, really is different from the late adolescent. The highest group for starting drug use is 15 to 17, but the spike starts at 13 to 14. And in a residential treatment environment or group home like you guys are in, we're going to see that spike even earlier just because they have so many other risk factors. When they perceive that parental involvement is low and peer approval is high, those are going to be the two most influential factors for encouraging them to start drug use. So when we look at the prevention efforts we have right now, the adult-led campaigns in elementary-aged youth are probably effective because elementary students do what adults say. But when you get into adolescence, what you're really looking for are peer-led campaigns because what did we say? Adult oversight, but peer approval is what's really important in the adolescent. So if we're looking at stage-specific campaigns, the early adolescent is going to be concrete, focused on the individual, really about here and now. The mid-adolescent can become more abstract. It's still self-focused, but you can put a little bit of an intermediate foresight, like what if this happens? And then when you get to late adolescent is really where you can go into those abstract type of preventions and future-oriented, like this is how this will affect your future. So to think about specific examples, the early adolescent, literally all you have to say is, if you smoke marijuana, your breath will be stinky. That will be an effective prevention method. It's concrete, it's individualized, it's in the here and now. But when you get to the mid-adolescent, then you will add on, marijuana causes stinky breath, and stinky breath makes it hard to make new friends. Because remember, the mid-adolescent is moving into a place where peer approval is absolutely the most important thing in their entire life. And then when you move to late adolescence, not only does marijuana smell bad, smelling like marijuana makes it hard to get a job. And this is where you would start talking about the legalization talk, because they'll actually be butting up against that age where maybe they could go buy marijuana without criminal impact, but it still might not be the best decision for them. So you can see how, depending on what stage of development the adolescent is in, your intervention has to be different. Okay? Same thing, intervention. At early adolescence, spice can make you freak out. Nobody wants to be freaking out. Mid-adolescent, spice can make you freak out, and oh my God, freaking out at a party would be so uncool, right? The late adolescent, although spice doesn't show in most drug screens, what consequences might you have from using it? So you can see how that thought process is like future-oriented, abstract cause and effect that the mid and early adolescent don't necessarily have the capacity to do. Alrighty, so let's run through a case to bring this home. We'll do this in about 5 minutes. And there's a repeating slide that comes in here. This is the tying it all together. This is how I want you to be thinking about it as we go through this case. Chronologically, what stage of adolescence is Jason in? Meaning based on his age. So he's 17, he's in late adolescence. Functionally, as we go through the case, does he seem to be in late adolescence, or does he seem to be stuck in mid or early adolescence based on the way his thinking is? If there's a difference between where he is functionally and where he is by age, what do we think contributed to that? What is his perceived risk of substance use? Because remember, that's what determines whether he's going to use. What is his perceived availability? What is his perceived parental approval? What is his perceived peer group approval? And then once we take all that information, what approach do we think is going to be successful for Jason? So let's take a look. Jason is a 17-year-old male who just finished his junior year of high school. So the answer to our first question, chronologically, he should be in late adolescence. Prior to this year, he was an honor student and was on track to earn an academic scholarship to any college of his choice. But about halfway through the academic year, he began dating Sarah, and I should say this is based on a real kid that I saw a couple of months ago. His parents, except his name wasn't Jason, obviously. Names have been changed to protect confidentiality. Jason's parents noticed that after he started dating Sarah, he began skipping school, he became more argumentative, his grades started slipping, and he seemed moody and impulsive. Now, mind you, when we see that collection of symptoms, I'm automatically thinking drug use. But his parents couldn't imagine that Jason would be using drugs. They thought Sarah is the entire problem, so they forbade him to keep seeing Sarah. Even though he stopped seeing Sarah, his behavior and school performance did not improve. Eventually, he was admitted to our residential facility, and his mother took him to the hospital reporting that he had attempted suicide by overdosing on Xanax. Okay? Now, the first question should be, does he have a prescription for Xanax? Because if not, where did he get it from? Chronologically, he's in late adolescence. Functionally, we don't know yet because we haven't talked to Jason. So we can't even get to numbers 3, 4, 5, 6, 7, or 8 yet. So let's take the next step. While you're interviewing Jason, you learn that the Xanax incident was not a suicide attempt. He says that he and Sarah had a fight, so even though his parents thought he stopped seeing Sarah, looks like he didn't, which is typical adolescent. Because what are they doing? They're individualizing from their parents, making their own decisions, not necessarily appreciating all the risk, right? He took 8 Xanax to calm down and go to sleep. He had no intention of dying. You review his record, and he has never been seen by a psychiatrist and had no previous prescription for Xanax. Specifically, you note that Xanax is not even on his current medication list. So you ask him, where did you get 8 Xanax from? And he answers matter-of-factly, I took it from my stock. What? So chronologically, we know that he's in late adolescence. Functionally, he might be closer to mid-adolescence because he's really taking risks without appreciating the future consequences, right? We don't know about number 3. We're about to get into number 4. Number 5, it was obviously very available because he had his own stock. Number 6, we don't know. Number 7 and number 8 we'll figure out in the end. So here's the next. Further discussion reveals that Jason has been selling drugs since the beginning of his sophomore year. Nothing serious, he says, just Xanax bars, marijuana, ecstasy, and spice. This is the typical adolescent drug combination, right? Prescription pills, marijuana, ecstasy, and spice. They see like very little risk in those. He reports that he began selling because his other friends were getting jobs, but his parents would not let him get a job for fear that it would interfere with his academic performance. Okay, so that's a little bit of a kind of a mid-late adolescent type of thinking. He's trying to individuate. He's kind of thinking about still in right now, I want a job right now. He did not want to be the guy with no money in his pocket. So now we know that peer approval is very important to him. In January of the past school year, he began using Xanax as his relationship with Sarah became more stressful. His use escalated to marijuana, ecstasy, and spice several times per week. He's not sure his parents even noticed the difference in him because they are always working. So there is our low perception of parental oversight, right? But he doesn't think his parents would be as mad about his using drugs if it weren't interfering with his academic performance. So there's our clue about his idea of parental approval. He doesn't even necessarily think his parents would be mad about drugs. What they're really concerned about is his academic performance. And so he's thinking, I can use drugs and perform well academically, and my parents will still approve of that. So you see how this is helping us formulate what interventions we're going to make for Jason. So chronologically, he's kind of like mid-late stage. Functionally, he seems to be mid-late stage, not too much of a discrepancy there. His perceived risk of substance use is low. His availability of substance use is high because he's the drug dealer. His perceived parental approval, he thinks they would approve as long as he can keep his academic performance okay. And his perceived peer group approval about drugs, we didn't specifically hear about, but about fitting in, he wants to have money like everybody else. So when we're thinking about what approach will most likely be successful, we know that we can use peer-based influences and a little bit of future implications when we're trying to make an intervention for Jason. So he says he doesn't plan to keep using drugs regularly now that he had to go to the crazy house because of it. He does not want Sarah to think he's psycho. So see how that's most important to him, what his friends think? Also, he's thinking if he didn't use so much of his own supply, he could be making more money. So while we don't want Jason to be a drug dealer, that does show us that he has developed cause and effect thinking. He plans to continue selling drugs until he turns 18 because at that point, he will likely stop selling except marijuana because the legal consequences get to be too much if he gets caught. Since marijuana will probably be legal by then, he thinks he'll probably continue selling that. So he definitely has future-oriented thinking, even though, you know, it's not the best decision making. He gives you an ability to talk about future implications of use, future implications of selling, and you know that you're going to have to talk about the effect it's going to have on his peer group because he has made it clear to us that that's what's important to him. So chronologically and functionally, he's mid to late. His perceived risk of substance use is low, except that he doesn't want to go to the crazy house, so that's how we can increase his perceived risk. His perceived availability, his availability is actually high. We want to try to talk to him about the risk of selling so that availability can get less. We want to get his parents on board to reinforce for him that they do not approve of drug use even if he can keep his grades up. And we want to talk about how his using and selling actually makes him not fit in with his peer group, and or talk about getting a peer group where he wouldn't fit in. So you see how we use numbers 1 through 7 to come up with an approach that would most likely be effective for Jason. So late adolescence, we can talk about long-term physical effects, future-oriented interventions. We can be more philosophical with him. We can focus on establishing independence because that's the whole reason he started selling drugs in the first place, right? And then your therapeutic relationship can become more intimate and complex with Jason because his thinking is developing along those lines. So these were our learning objectives. I hope you feel like we met them. Discuss the implications of legalization, discuss current trends in drug use, and apply the knowledge of those trends and implications when trying to design prevention and intervention strategies for our adolescents. That is it. So are there any questions or discussion?
I've been watching the chat and the question box. I haven't seen anything come up. So if anyone has any questions, please enter them now. And we'll just wait a few moments. Okay, I'm not seeing anything. So I think we can wrap things up. Thank you so much, Dr. Harrison. That was quite a wonderful presentation, really interesting, and I really enjoyed the case study. And now, good. Now, before we sign off, I just want to thank everyone else for their time and for joining us for this webinar. Please remember to complete your evaluation, the sign-in sheet, and then fax these materials back to me by Friday if possible. Thank you again, and enjoy the rest of your day.